So welcome, Nick. You're a very experienced imaging cardiologist, and we're looking forward to what your views are on the current opportunities and challenges that the COVID pandemic has brought us in the field of cardiac imaging. Thank you.
Thank you, Paco. So we've changed, COVID's changed the way we undertake cardiac imaging completely. And I'll briefly talk about each of the individual modalities and then talk a bit about diseases themselves, and then how we have changed our practice in the COVID era and how we think it's going to change in the future. There's going to be lots of generic issues, but social distancing is going to continue for some time, and PPE is going to continue without doubt until vaccines are created. But there are some very specific modality issues in terms of running a lab. I'll talk about some of them, but all the societies have generated guidelines to follow, and we don't need to reiterate that. So I'll mainly talk about how we've changed our management in terms of disease process. We've changed things significantly towards telemedicine. The history taking is absolutely crucial. A thorough, detailed history is essential, and combine that with the ECG from primary care, and you can definitely make a diagnosis in a significant number of our patients without any further testing. And that's why we've set up threshold for testing much higher than it has been in the past. We're very keen on targeted investigations, aiming for high specificity, i.e., which is the test which is going to give us the answer, rather than take the let's do a test to make sure you haven't got disease process X, Y, or Z. Ruling out a disease with imaging is something we've all fallen into. It's partly defensive medicine, it's partly the way we are trained, but we have to almost come out of that mold now and concentrate much more on how can we improve our specificity and go for targeted investigations absolutely required. So when it comes to sort of my general rules, I tend to rely very much on high-risk symptoms. So the patients I will ask to see face-to-face are those with new onset PND, orthopnea. Syncope, especially exertional syncope, does worry us, and we will see those patients quickly. Unstable chest pain is clearly that needs sorting out, and it can be difficult by telephone, can be done. We'll quite often see them in clinic directly. But the pre-test likelihood, before we do any test, we have to calculate the pre-test likelihood. That is absolutely crucial. So chest pain in a 21-year-old who's fallen over, having done lots of new extra sport or just gone to the gym and been pumping some weights, it's very unlikely to be cardiac related. So we have to bear those sorts of things in mind. When it comes to COVID-specific patients, we need to think about scanning them maybe at the end of the day in order to allow for a deep clean afterwards. These cleaning regimes have to be followed. We can't make any changes to those, and we have to be prepared for staff absences depending on workload, stress, and also illness from the COVID itself. So our echocardiogram department's changed enormously in the last 6 weeks. We are offering far fewer appointments, and as a result, our waiting room is very quiet. We can have 1 or 2 patients in there at a time. It's very easy to socially distance, but because we're targeting our appointments, our waits are much shorter. Routine waits are now just a few days. So we can do a teleconference with a patient, and if we think they need an echocardiogram, they can come into hospital and have it within a day or 2 without any other patient interaction, 1 interaction with a member of staff, and can leave within 30 to 40 minutes. So it's very straightforward. And because we've increased gaps between our appointments, this allows for cleaning and allows for make sure there's plenty of social distancing. For stress echo, we are trying to do more exercise echo, and that must be preferred. We know that dobutamine echo in particular has a small but increased risk of VT-VF, and the last thing we need is a cardiac arrest with sort of the issues associated with it in the COVID era. So exercise stress, physiological stress should really be preferred for those patients. And for patients who need TOE, we know that level 2 PPE is required, and I don't think that's going to change in the immediate future. We need to make sure our transthoracic echo is as good as it can be, and if it isn't, and they're still concerned particularly about valve disease or function, then CMR is an excellent modality to use as an alternative for TOE. But clearly that will have its own implications on waiting times as well. In nuclear cardiology, we haven't really changed much of our practice. Exercise stress is our preferred option. We very rarely use dobutamine. We do use a lot of vasodilator stress, but the risks from that are incredibly low. So apart from waiting rooms, social distancing, there's been no major change. Our waiting times have fallen, and we are scanning fewer patients, predominantly because we are targeting our investigations and concentrating particularly on urgent cancer, urgent chest pain, and those sorts of indications. From a CT cardiac MR point of view, the only major change is PPE for the staff. Scheduling is important. If you're fortunate to have more than one scanner, you could potentially dedicate one to COVID. That clearly isn't always possible. The only specific issue with CMR would be in those institutions that use dobutamine for stress, probably try and avoid it. It's very unlikely to have a complication. It's still very low risk, but we need to be careful about from that point of view. Cleaning regimes for both of these larger scanners are going to be more complicated, and those sorts of factors need to be weighed in. So controlling the indications will help maintain smooth patient pathways through the system. When it comes to specific diseases, the way we work locally, if we suspect heart failure, but we know we have a chest X-ray and an ECG, if you have a normal cardiothoracic ratio on the ECG, on the chest X-ray, and a narrow QRS on the ECG, you're very unlikely to have systolic dysfunction. And as a result of that, we can potentially avoid bringing patients into hospital who we're worried about, who might need an echocardiogram. Biomarkers are crucial. Combine the CTR, the QRS duration, and a low BNP, and effectively we've excluded systolic dysfunction. The diastolic parameters are less important now, I would suggest. It's limited utility in every patient, and therefore stripped down transthoracic protocols are probably going to be the norm. Rather than taking a full BSE data set, we'll strip them down into ventricular function, valves, maybe EA ratio, and not too much else, because we know when it comes to diastolic heart failure, risk factor control is important. We should concentrate on the diabetes and the blood pressure control. When it comes to valve disease, our valve clinics are now virtual. In patients with known regurgitation, we rely very much on symptoms, and if we're unsure if the symptoms are getting worse, we'll now use a trial of diuretic therapy as an empirical treatment and see how patients respond. This does require calling them back, seeing how they're doing. Stenotic valve lesions are always more concerning. We rely very much on symptoms and also changes in exercise tolerance. They're very important. Again, a trial of diuretics can be reasonable, but if you're still not sure, objective evidence with an ultrasound is what's needed. But we can target these patients and avoid a lot of unnecessary scans in patients with mild to moderate lesions. The chance of them progressing significantly in the space of 6 or 12 months is very low. When it comes to palpitations, we all know the red flags, the syncope, severe chest pains, breathing difficulties, drop in exercise capacity, all those sorts of things are important. But a detailed history, most of our patients will have benign ectopics. An ECG is good enough as long as there's no QT prolongation, widen QRS. We can then say and be reassured with these patients. And if clearly they need follow-up in the sense that if things don't settle, bring them back in for further testing. But otherwise, we should have a fairly high threshold to investigate benign sounding palpitations. When it comes to cardiac sounding chest pain, we should follow the evidence, medical therapy for all, and we should be really quite aggressive with our medical therapies. If there's still ongoing concern, CT would be very helpful to make sure we haven't found proximal disease. From a prognostic point of view, that's important. We may miss the more distal disease, but we know from a prognosis that's less important, and trials of medical therapy are important in those patients. If we're still stuck, we know we'll have to do targeted ischemia or go straight to FFR testing with angiography. That might be another method of targeting patients appropriately rather than doing layers upon layers on tests to work out what we already know. And if we think they're going to need revascularization because they failed medical therapy, a straight to angiography regime may be indicated in certain patients. More specialized clinics are very difficult in terms of dictating. You have to really have an individualized case-by-case approach for ACHD patients, and the people who run those departments will have a good idea for the patients who will need imaging. who are safe to come into hospital as well and do that risk assessment. Same also for pulmonary hypertension, but again, symptoms really very important before bringing patients back in for more testing. ICC clinics will still continue, but clearly cascade echoes and CMR screening in asymptomatic relatives, I suspect will need to be deferred until we've managed to reorganize all of our services. So the way we've changed our practice is that the history is, and with an ECG, is absolutely paramount. This is the most important way of risk stratifying our patients. We need a certain level of experience to do this. This isn't something we can leave to less experienced colleagues or more junior colleagues. If there are concerns about whether tests should be done or not, an MDT approach is not unreasonable. We may end up discussing more of these patients, either in a formal or an informal setting, in order to decide, is it worth bringing them in for advanced imaging with tests. Working out the pre-test likelihood is therefore crucial. Benign palpitations in a low-risk individual, it can be left alone. Central chest tightness on exertion in a 70-year-old diabetic is angina, and we can treat it as such. Therefore, we need to decide, are we doing our tests for diagnostic reasons in order to treat them, or should we just treat them? Or are we doing tests for prognostic reasons, in which case it might be more valuable to do a test in very specific groups of patients from a prognostic point of view. Therefore, targeted imaging has to be individualized. We're going to have to do a lot more review of symptoms. If we take this approach, we'll have to recontact patients a bit more frequently and say, how is that change in medication? Do we now need to rediscuss a different strategy? Do we now need to introduce imaging or something else? So this regular review of symptoms is important, and we need the right IT infrastructure, which allows us to keep in touch with our patients in order to see how our empirical medical therapy trials are working. Thank you.
Sorry, thank you, Nick. That's a very nice presentation, and it underlines really the difficulties that we face. Clearly, we cannot have the ambition of satisfying the guideline, the recommendations that we're all familiar with, clearly because this is a different reality. With respect to the management of chest pain, I absolutely agree that if a patient has convincing chest pain, which in the eyes of an experienced clinician is worrying, we should perhaps do away with layers of CT or exercise testing or other non-invasive techniques and proceed just to straightforward coronary angiography if you're convinced. And it seems to me that your message is similar to that. Is that right?
Absolutely. We have taken an approach where initially we've concentrated more on CT as a way of using it as a rule in, rule out. And in fact, for our ACS patients, we were starting doing hot CT to look for occluded arteries, which in non-dominant vessels, in which case they don't need to go to the cath lab. So we've tried that, and that works quite well. So there may be a way of keeping people out of cath lab, but certainly in outpatients, if you've got a really good history in someone with lots of risk factors, my view is we should treat aggressively with tablets. And if it's not settling, probably go straight to the cath lab and miss out all the other layers of testing.
I mean, the other difficult population is the echocardiograms on cancer patients. And one could possibly apply the same sort of guidance. They're very rarely abnormal. Obviously, we do see them. But I do wonder whether one should, at this point, even though the evidence is not strong, whether one should rely on just BMP. What's your view of that?
That's a very good point. So we've already slightly altered our oncology echocardiograms for LV function assessment and moved things from 3 months to 4 months in order to reduce some of the stresses on the patients who are clearly concerned about coming to hospital whilst they're on chemotherapy regimes as well. So they have those concerns as well. And that also is a burden on us to explain that to patients as to why we might still need to bring them in. But I think a BNP test with a telephone history, exercise capacity, breathlessness, very important. and we could potentially change the way we look after oncology patients. We still have to offer some service. We still have to be able to see patients. But you're absolutely right. The likelihood of symptomatic LV systolic dysfunction we know is low, and generally patients will want to carry on their therapy. We will, if someone has a raised BNP, we could empirically even start an ACE inhibitor if we really didn't want to bring to hospital. But then again, if you then say, I still need to know LV function, you could do a targeted echo in 5 minutes. No ECG, bring in, just look at the LV, no major, bit of color flow, done. You could be done in 5 minutes and get the patient out, and the risks then are very, very low. So we've already moved to a similar sort of model where we're trying to do 5-10 minute targeted LV function echoes on oncology patients.
Yeah. Great, Nick. That's very nice insight into imaging. Clearly, these are difficult times, and we have to compromise, don't we? We have to throw away a lot of the things that we've been doing for years, which are obviously good for patients. But in these circumstances, it's all about weighing up the risk of the real risk of infection from COVID and getting marginal results from imaging.
Completely agree. And don't forget, we have to have a collegiate approach to this. Our colleagues have to have buy-in that this process is better, that it's not rationing. We're doing this for the safety of our patients. We're not doing this to save time or money or anything like that. And explaining this to colleagues, maybe outside cardiology, is probably more important than inside cardiology, so that our oncology colleagues, acute medicine, surgeons, anaesthetists understand this is why we're doing it. And, bringing back the stethoscope is not a bad thing we should be doing.
Sure. Brilliant, Nick. Thanks very much indeed.
Not at all. Thanks, Paco.